জাকির স্যার, সবাইকে আসসালামু আলাইকুম। হাফিজ ভাই আসসালামু আলাইকুম। সাব ভাই আসছেন না? আতার ভাই, ওই আতার ভাই আসছেন। আতার ভাই আনমিউট করে রাখেন।
স্ক্রিন শেয়ার হলে
তুষার ভাই, আপনি এখান থেকে জাস্ট 10 সেকেন্ড পরে কথা বলা শুরু করলেই হবে। আপনার 10 সেকেন্ড।
ওকে। 9, 10, 7, 6, 5. Should I start?
Yes.
Okay. Assalamu alaikum and good evening to everybody. Today we have 16th lecture on our ECG study group lecture series. Today's topic is ECG in atrioventricular block. Our today's speaker is Professor Dr. M. Atahar Ali sir, and I request Professor Abdul Wadud Chowdhury sir to say a few words about Professor Atahar Ali sir, and then we start the program. Wadud sir, assalamu alaikum.
Assalamu alaikum and good evening to everybody. I think it's superfluous to say anything about Professor Atahar Ali. Atahar Bhai is so well known to everyone, at least in Bangladesh, and I think many parts of Nepal and also Maldives and Malaysia. One thing I can say about Atahar Bhai, he's curious, he's very much accessible, he likes to make things simple, and he's a very good teacher. He can present complicated things in a very simple way. And he has been a pioneer EP specialist in this country under the able guidance of our beloved Rafique Ahmed sir from America. And he has got two very apt students, Prof. Atahar Ali and Prof. Mohsin Hussain. And they have been the pioneers in our electrophysiological field, who are also creating many others, juniors, getting ready for providing their service in the field of electrophysiology throughout the Bangladesh. Today, Professor Atahar Ali is going to talk about atrioventricular block in its different manifestations, from first degree to third degree and in between. Before that, we have had talk about bundle branch block, and the next step, obviously, is the complete block and then between atrium and ventricle. We are going to have a very exciting lecture today from our very beloved Professor M. Atahar Ali. Atahar Bhai, Roger, you are on.
Sir, it might take some time. Sir is preparing to update his lecture.
No, actually, I'm begging apologies because there is an unstable internet connection in my room. So
Okay.
just a few minutes, a few seconds.
এর আগে আপনার হাইপারট্রফিক কার্ডিওমায়োপ্যাথি লেকচারটা স্যার খুব এনজয় করছি।
আচ্ছা, এখন তো ঠিক আছে, দেখি। আচ্ছা, স্লাইড শেয়ার করি।
তাহলে আপনার কাছ থেকে স্যার একটা কেস বেস লেকচারে হাইপারট্রফিক কার্ডিওমায়োপ্যাথির উপরে আমাদের ইসিজি স্টাডি গ্রুপে আপনি ইনক্লুড করলে খুব ভালো হয়।
জানাই আমাকে অবশ্যই।
স্যার
এটা সাইডে দাও তো। কর্নারে Okay. Hello, Tushar, can you see my slide?
Yes, sir. Yes, sir. We are seeing your slide.
We can also hear you quite well.
Yes, sir.
So, good evening and welcome everybody, particularly our Honorable International Advisor, Dr. Rafique Ahmed sir, and also Dr. Chowdhury Hafiz. And also we have got some international, sir, our local, very special faculties like Professor Zakir Hussain and some other also. And dear faculties, today's lecture on the AV block. Depo. Depo. So AV block, just brief introduction about the AV node. We know the AV node is a tadpole-like structure, very small structure, lies sub-endocardially at the lower part of the right atrium, just along the interatrial septum. The main function of the AV node is AV nodal delay. And the AV nodal delay is physiologically very important because it protects the ventricle from higher atrial rate when it occurs, as for example, in the case of the atrial fibrillation or some other ventricular tachycardia. And this AV delay is physiologically very important because it is very physiological component for the atrioventricular synchronization. That is atrial systole follows by the ventricular systole. There does not overlap between the atrial and systole, and it is because of the AV delay. So AV node plays important role, and delay, that is making some block, is the physiological function of the AV node. But when it describes the pathological situation like the AV block, there is atrioventricular block. It means partial or complete interruption of impulse transmission from atrium to ventricle. This is the pathological situation, and this is called the AV block. And but AV delay, this is some kind of the block, and this is the physiological properties of the atrioventricular node. When ECG is the main tool for describing the any kinds of the block in the conduction system, particularly either SA node or AV node or the infra-nodal structures. This is one of the ECGs on the left side. We can see the first bit is a QRS complex, narrow QRS complex. There is no P wave before it. So it can be the junctional bit. But after that, there is a bit that is preceded by the P wave. That is the atria, that is the sinus bit that is conducted. So this is the group. That is one, the escape bit, that is the supraventricular, particularly from the maybe the junctional bit and the sinus bit. But there is a pause. What is the reason of this pause? There is no activity. But after this QRS complex, we cannot see the P wave nor the QRS complex. Just before seeing another the escape bit, that is the supraventricular bit without the PRS complex. So this is one kind of the block, as because this sequence is not maintained here. This is one kind of the block. But what kind of the block it is, whether it is the acerodal block or evinodal block or something else. So this is the ECG that can tell us the answer. And this is another ECG. You can see this is the narrow complex regular tachycardia, that is the supraventricular tachycardia, that stops and degenerates into the atrial fibrillation. And thereafter, there is again atrial fibrillation with the long pause, but there are multiple atrial activities. But these atrial activities are not followed by the QRS complexes. There is another QRS complex. So there is a different kinds of the block at the AV node. This is also one kind of the AV nodal block. This here the supraventricular tachycardia, we don't know what kind of the conduction is taking here, but here we can see there is the atrial complex, and not all atrial complexes are being conducted. And here clearly you can see there is many of the atrial complexes are not cleared. So there is a block in the AV node, where whether it is physiological or pathological, that is the question. So what I want to make you understand is that ECG is the main tool for describing the different kinds of the block whether the location of the block or what kind of the block it is. So Evercare block, it is usually commonly you can say that is the congenital or acquired, and acquired block again can be reversible or the permanent. These are the examples of the reversible block because of the high vagal tone. Sometimes it is drug induced or the metabolic condition like the electrolyte imbalance. So these are the reversible causes of the AV block, and these are the permanent cause, that is the degenerative. This is the one of the commonest cause, and after the myocardial infarction or sometimes happens after the iatrogenic, particularly post cardiac surgery or the ablation. So these are the causes of the AV block, that is the congenital or acquired, reversible or permanent. For evaluation of the Evercare block by ECG, we have to answer 3 questions. That is the degree of the block, origin of the escape rhythm, and the level of the block. We can get answer of all the 3 questions from the ECG evaluation. So these are the things we have to evaluate from the ECG about the Evercare block. Degree of the block. Degree of the block means first degree block, that is prolonged conduction. That is, there will be conduction of all the P waves, but with taking the longer than the physiological time. There is the prolonged condition. This is not actually the block. This is actually the delay. Then the second degree block, there will be intermittent conduction of the P wave. Not all the P waves will be conducted, but some of the P waves will be conducted. And third degree block or the complete heart block, that is, none of the P waves will be conducted. So this is the simple way of defining the degree of the block, that is the first degree, second degree, third degree. Prolonged conduction, intermittent conduction, or no conduction of the P waves. So this is the simple way to keep it in memory, that is to define the Evercare block. And we have to also define the level of the block and the level of the, that is the origin of the escape rhythm. There is a good correlation between the level of the block. Physiologically, usually the escape rhythm comes just side after the level of the block. As for example, if the block is the AV node, the escape rhythm will be usually from just after the AV node, that is the distal to the AV node, usually from the junctional area, where the physiological rate is 40 to 60. Or if the block is in the infra-nodal area, particularly in the His bundle, the escape rhythm usually should be from the bundle branches, usually at the rate of the 40 to 50. Or if the block is in the bundle branch level, the escape rhythm may be from the ventricle. The escape rhythm is usually 20 to 40. So this is the simple way, but this is not the exact rule that heart always follows. But this is the physiological principle of the heart that is usually followed, and usually the escape rhythm comes just from the level of the distal to the level of the block. So this is one of the example of the first degree AV block. We can see in the first ECG, the PR interval is 220 milliseconds. More than 200 milliseconds is first degree AV block. This is the P wave, and this is the QRS complex. So this is the first degree AV block, and this is the delay actually than the block, as because all the P waves are being conducted, just taking more than physiological time. So this is the this is actually a delay rather than the block. That is the first degree block is a kind of the prolonged delay than the real block. It is associated with the diseases most of the time, but sometimes it can be seen even in the physiologically, that is the normal population up to 4% after the age of the 60. So this is not uncommon in the physiological situation. In the lower ECG, the PR interval is more prolonged, profound prolongation, that is the 420 millisecond. In contrast to the 220 millisecond, here the P wave is 420 millisecond. And this P wave is actually positioned just at the terminal part of the T wave. What does it mean? The ventricle is still in the systole, and the PR is positioned just during the systole of the ventricle, the terminal part of the systole. That is, the atrial systole will happen when the ventricle is still in the systole, and ventricle will be in the diastole. So the position of the P wave or the degree of the first degree block sometimes determine whether the patient will symptom or not. Usually it is stated that the first degree heart block is usually asymptomatic, does not produce any hemodynamic consequences, but this is not the true. This is because the position of the P wave is the degree of the block is profound, usually more than 300 milliseconds. The P wave position will be backward over the T wave, and depending on the position of the P wave, there will be coincidence, that is the overlapping of the ventricular and atrial systole, and that determines the patient will have the symptom or not, as for example in this case. So the clinical significance of the first degree AV block, this is not always asymptomatic. Here in this case, the patient will develop the pseudo pacemaker syndrome, just like the pacemaker syndrome, as because there will be overlapping of the systole of the ventricle and the atrium, as because the P wave is positioned just during that is just before termination of the ventricular systole. So there will be pseudo pacemaker syndrome, and it will also overlap early part of the diastole of the ventricle. So it will produce the diastolic mitral regurgitation, and longer the diastolic mitral regurgitation, over the periods of time, the patient will have the dilated left atrium that will produce the atrial fibrillation. And this is the region, the profound first degree AV block with symptom is a kind of this is also included in the guideline for the pacemaker implantation. So the first degree heart block is also included in the guideline for the pacemaker implantation during such a kind of the situation, not always, whether it is related to the development of the symptoms or this is the situation. So the first degree heart block is not always hemodynamically benign. It may be symptomatic and it can produce some kinds of the pathology like this. This is another example of the first degree heart block. That is, the first degree heart block is not always easy to diagnose. As for example, in this case, here in this say, this is the PR interval. In the first part of the ECG, you can see this is the PR interval. That is the normal looking PR interval. This is the P and this is the QRS complex. So this is the PR interval. But here, the PR interval is longer. So by definition, this is the first degree heart block. This is the first degree heart block. But what is the explanation? The same ECG. This patient has this kinds of the PR interval, and again, here this is the P, this way. So sometimes we can see in the same ECG of a patient during the same times may show the two kinds of the PR interval. One is physiologically normal, and another is by definition this physiologically longer, and by definition we can say this is the first degree heart block. What is the reason? If we see like this, there are the two differential diagnoses. One is that is the PR interval normal and the long. One differential diagnosis this patient may have, that is the two pathways in the AV node. What happens in case of the AVNRT? There are two pathways. That is the alternatively the atrial impulses may be conducted sometimes through the small, that is the first pathway that will give these kinds of the PR interval, or the PR, that is the atrial impulses can be conducted through the slow pathway when this PR interval is seen. So this is one of the explanation. But another explanation is concealed conduction like this, as because just before this prolonged PR interval, we can see this is the ventricular extrasystole, that is the ventricular ectopics. This ventricular ectopics like this from this ECG, if you can see, if the ventricular ectopics comes from here, and if it enters into the conduction system and proceeds retrogradely toward the atrium, so there will be some kinds of the block within the conduction system, and the upcoming atrial impulse will take longer time producing the longer PR interval. So this is one of the explanation of the concealed conduction of the supra, that is the ventricular ectopics, that can produce these kinds of the longer PR interval. So by definition, as it is more than the 200 millisecond, this is the first degree AV block, that is the prolonged PR interval. But explanation is like this. So this prolonged PR interval is because of the concealed conduction. So in the same ECG, we can see sometimes that is the normal PR interval or the longer PR interval, and the possibilities are like this too. The second degree mobis type, the mobis type is, we know that is the mobis type 1 and the mobis type 2. Mobis type 1 means progressive lengthening of the PR interval. This is the PR interval. You can see the first ECG complex, the normal PR interval, the second complex, longer, third complex, further longer, then the PR interval is dropped. So this is the progressive lengthening of the PR interval as defined in the mobis type 1. So this is the non-conductive. These kinds of the pathology almost always happens at the level of the AV node. But this lengthening is not always similar in all the cases. Sometimes the progressive lengthening we can see, but sometimes There is sudden lengthening, that is PR same, PR same, PR same, sudden lengthening and then drop. This is called the atypical Wen back. So Wen back may be either typical or atypical in case of the mobis type 1 ECG, that is Evercare block. This is one of the example. You can see this is a pause, this is a pause, and this is the P conducted. This is the P conducted with the prolonged PR interval. This P is conducted with further prolonged PR interval. This P is conducted with again further prolonged PR interval, and this P is conducted not conducted. So this is the progressive, slowly progressing of the prolonged, that is the PR prolongation of this piece plot. So this is classic example of the mobis type 1 AV block. And the characteristics of the mobis type 1 AV block is not only the progressive lengthening. There are some other features that helps to define the mobis type 1 block, that helps to see when there is a problem like the diagnosis, there's the mobis type 1 block. As for example, here, there will be a groove. As for example, you can see, this is the first bit that starts conduction, again, and this is dropped. So this is the group, and we can see, again, this is the group. So there will be repetition of the group. Before and after the drop, there will be repetition of the group. Again, the RR will be variable. As for example, the RR is not fixed, the RR is variable. And another important feature is that this is the dropped bit, this is the blocked bit, this is the P wave with the pause. And if we see the PR interval after the pause, this is the PR interval after the pause, and this is the PR interval before the pause. So the PR interval before the pause will be longer than the PR interval after the pause. So these are all the features of the mobis type 1. That is not only the progressive lengthening, this is the group beating, as well as the RR variable type of the block when there is a confusion. So these are the characteristics of the mobis type 1. What type of the block here it is if we apply? As for example, this is the conducted sinus bit. This is the conducted sinus bit, but with a prolonged PR interval. But what is here? This is the bit we can see. We cannot see the P, but possibly this is the P. So PR, this is the prolonged PR. This is the further prolonged PR, and there is a pause, but we cannot see PR. We cannot see any P here. So what it can be? Is it the sinus pause, or is it the AV block? What is the answer? So this we can face during the differential diagnosis of these kinds of ECG. But another characteristics, what we see, if we look carefully, there is a group. This is a group, 1, 2, 3 group. Just at the bottom strip, 1, 2, 3 group, 1, 2, 3 group. So this is likely to be the mobis type 1 block. And now we can see the T wave here, the T wave here, and the T wave here. Possibly this is distorted and should be the position of the next P wave should be here. So sometimes the mobis type 1 AV block diagnosis is not easy. We can face sometimes of these kinds of the problem for diagnosis the Evercare block, and it can produce sometimes confusion with the sinus pauses. But not always. Sometimes the examples are very clear and classic, like here. This is the group. This is the one group. PR, P conducted, P prolonged PR conducted, P dropped. Repetition, PR, PR drop, PR, PR drop. So there will be a classic grouping of the mobis type 1 first degree heart block. So if ECG is like this, there is no confusion. But if ECG is like this, there will be a problem. This is another example. What should be here? What can be the diagnosis? This is the P conducted, P conducted, P conducted, P conducted, but this P is dropped. So definitely this P is blocked. So what is the reason? Is it the second degree block, or it is the paroxysmal atrial contraction? This is one of the ECG of my patient. I may be wrong. I want the explanation from Rafique sir afterwards. But what explanation I want to give, that this P is showing the atypical ONK back. That is PR. Here the PR is slightly longer, but it is difficult to say. But there is a sudden prolongation. So this can be one of the example of the atypical ONK back. And this is one of the, this is the group. And again, this is the group. This is the group. This is the group. So the presence of the group beating and sudden prolongation all explains that this can be the AV nodal block and mobis type 1 block rather than the paroxysmal atrial contraction. But PAC definitely gives one of the important differential diagnosis for defining these kinds of the ECG. So mobis type 1. This is another example. I like to draw attention from Rafique sir. What can be there? This is again the ECG of my patient. That is, this is the P and conducted. This is the P conducted, but there should be another P, but there is no P. There is no P. We cannot see the P. Rather, there is an escape bit. That is some distorted morphology, the escape bit. So P conducted, the P is blocked. There is no P. This is the escape rhythm. So what could be the explanation of this ECG? Possibly, definitely, this can be the one of the differential diagnosis, whether that is the paroxysmal atrial conduction that is blocked here, or it can be the second degree AV block. My explanation is that it is the mobis type 1 block, as because the PR is prolonged. This is the mobis type. I don't know. That will be the first degree or the second. This is the mobis type. That is this PR is prolonged. This P is dropped, and the further prolonged. So there is the escape rhythm. So sometimes we can face sometimes these kinds of the ECG for defining that. That is the definition. That is the diagnosis of the mobis type 1 or mobis type 2 is not always straightforward. These are the problems that you can face during the diagnosis of the ECG. There is another ECG. Is it the second degree AV block? As for example, this is the P and conducted bit, PR. This is the P and conducted bit, PR. This P is dropped. PR, PR dropped. PR, PR dropped. So what kind of the block it can be? So explanation is that there are the two possibilities. Yes, it can be the second degree AV block, as because this T is distorted. This T is distorted. Possibly the P of this QRS complex is positioned over the T, and that have given some distortion here. Here in V1 we can see clearly. This is the P conducted. This is the P conducted, but P is dropped. So what could be the explanation? Either it can be the concealed conduction, or it can be the second degree AV block. So most likely it can be the concealed conduction that produces the second degree like ECG. So concealed conduction of the previous atrial conduction is important differential diagnosis for the type 1 or type 2 second degree AV block. That is the main message of this ECG. Then second degree mobis type 2 AV block. Here we see that is mobis type ECG AV block. This is the P that is not conducted. This is the P conducted. This is the P conducted. Again, this is the P is not conducted. So intermittent conduction of the P wave. That is the intermittent conduction of the P wave. But when it is conducted, as for example here, the PR, as for example here, the PR, that is the PR is constant, but some of the P's are dropped. But when it is conducted, the PR will be the fixed. So this is the criteria of the second degree AV block. That is PR that is the constant. Some of the PR dropped. So number of the P wave will be more than the number of the QRS complex, definitely. So this is the characteristic of the mobis type 2 second degree AV block. And this is one of the example. What can be the explanation? That is this is the P QRS. That is the P is conducted, P dropped, P conducted, P dropped. The RR interval with the conducted P waves is same. This is the RR interval of the conducted P waves, RR interval of the conducted P waves, but the RR interval around the non-conducted P is again fixed. This RR interval around the non-conducted P, this RR interval against the non-conducted P, these are also fixed. So RR with conducted P is fixed, RR without conducted P is fixed, PR is fixed. These are the classic features of the second degree mobis type 2 AV block. But second degree mobis type 2 AV block is not always straightforward for diagnosis. As for example, this type of the case. This is the P conducted. This is the P conducted. There is clearly 2:1. That is the 2 P wave, 1 conducted with 2 P wave, 1 conducted. So what is the type? Whether it is a type 1 or type 2, it is very difficult to say and not possible from these kinds of the ECG. unless we see the two contacted P waves. It is possible. If we see two contacted P waves, this is one of the contacted P wave. If there were another contacted P wave, it was possible. As because we can compare the PR of the two contacted P waves. But when there will be 2:1 like this, only single contacted P waves, it is not possible from surface ECG to define what is the type. But the clues from the ECG can help to define what can be the type, whether the type 1 or type 2. This is the clues lies as, for example, in this ECG. PR interval. PR interval is an important clue. As for example, in this ECG, the PR interval is normal, but this is one of the clue. That is, PR interval is not always normal. QRS morphology. The QRS morphology is here also normal. This is another important clue. And sometimes the other evidences like evidence of the myocardial infarction, as because in this case, the evidence of myocardial infarction, what usually happens in the infra-nodal location. So these are the clues in 2:1 AV block that helps to define whether it is the type 1 or type 2 AV nodal block, that is mobis type block. As for example, in this ECG, this is the 2:1 AV block again. That is the conducted P, conducted P, conducted P. That is 2P, 1 QRS, 2P, 1 QRS. That is alternate bits are conducted. So again, this is the 2:1 fixed ratio AV nodal block. What is the type? Whether type 1 or type 2? And we should know it as because it guides the patient management. That is type 1 usually in the AV nodal, and type 2 is almost always it is the infra-nodal, and prognosis is different. So it is important point for defining from this ECG. So what is the message? That is, other than this type kinds of the conduction, the other clues that helps to define the type of the ECG. As for example, here, the PR interval is prolonged. PR interval is prolonged. The QRS morphology is right bundle branch block type. That is, PR is 300 and RBB morphology. That is, this is the 2:1 AV block with prolonged, that is first degree AV block also. That is the prolonged PR conduction, and the QRS is not the normal. The QRS is the right bundle branch block morphology. So these are the clues with the 2:1 AV block that helps to define what type of the AV nodal, that is the mobis type 1 block it can be. It is from this ECG we cannot say neither type 1 or neither 2, but these clues will help to guide that is the what type of ECG. So finally, the second degree AV nodal block may be mobis type 1, that is at the level of the AV node, mobis type 2, usually infra-nodal, or 2:1 that happens either at the AV node when it is mobis type 1 or in the infra-nodal when it is mobis type 2. So second degree AV block are of the 3 types, not the 2 types only. These are the three types of the second degree AV block. And these are the some important tests that helps to define the level of the block in case of the 2:1 AV block. And among the tests, these two are the very important point. That is the duration, that is QRS duration and the morphology, and the PR interval. These two are the very important point for defining the that is the type 1 or type 2. As for example, if the type 1, then the location is in the AV node, or the QRS will be usually narrow, and the PR interval will be more than 200 milliseconds. But when it is location is the infra-nodal, the QRS duration will be usually wide, but PR interval will be narrow. With these two ECG findings, what we can see in the ECG, these are the other points that also helps to define type 1 versus type 2, like the exercise and the atropine. Exercise and atropine improves the conduction, and in case of the infra-nodal, it worsens the conduction. So these are the ways, these are the some of the tests and the ECG clues that helps to define between the type 1 versus the type 2 ECG, that is AV nodal conduction. This is one of the example how the clue can help to define. Example, as for example, that this is the 2:1, 2:1. This is 1P, this is 1P, this is 1P, 1P. So 2:1 conduction, and the PR is fixed. This is the PR, this is the PR, this is the PR. The PR is fixed, and the PR before the conduction of this non-conducted bit and after the conduction of this non-conducted bits are same. So this is the mobis type 2, and location is infra-nodal as because the QRS is actually RBB morphology. So normal PR and RBB morphology QRS complex from this previous slide, we can see that is the QRS, that is the normal PR and widened QRS. So normal PR and widened QRS, that should be the type 2, mobis type 2, and location is the infra-nodal. This is very much important, and we can find these findings from this single ECG. So what is the importance of defining the nodal versus infra-nodal is because the infra-nodal, in case of the infra-nodal block, the escape rhythm is usually slow, the escape rhythm is usually unstable, and the pathology is usually irreversible, and risk of asystole is very high. So these are the groups of the patient we have to identify, as because most of the times they are the candidate for the permanent pacemaker implantation. So this is the reason why should we are concerned about the differentiation between the nodal versus infra-nodal location. But the second degree AV block sometimes can be further advanced. That is high degree AV block, what we can say. That is not that it is the 2:1. Sometimes there are 3 or more of the P waves can be non-conducted. That is the 1P, 1P, 1P. Initially, this patient has got 1:1 conduction, but suddenly it advances to 3:1 conduction, 3:1 conduction, 3:1 conduction. So this is the example of the high degree AV block that is advanced from the that is the 1:1 conduction in sudden development of the advanced AV block. This is one of the example of the this is advanced second degree AV block, or some books it is written as the high degree AV block, advanced second degree or high degree AV block, what you can say. But this is not the third degree AV block, as because there is evidence of the P wave conduction, that is evidence of the AV nodal activity. So this is not the third degree AV block. So this is the high degree AV block. This is another example of the high degree AV block. This is the P wave, P wave, P wave, P wave, P wave, P wave. This is the high degree AV block, and here the QRS is the RBB morphology. So definitely it should be the infra-nodal location, and the PP interval is fixed. So this is the one of the example of the high degree AV block, and location is usually almost always it is the infra-nodal location. And another type of degree of block is the third degree AV block. What we can say, the complete heart block, the level of the complete heart block may be AV node or the infra-nodal, and the pathology may be reversible or irreversible, and P QRS ratio, P is usually more than the QRS number. So these are the some of the characteristics of the third degree AV block, and we can see here, and we know all the characteristics. That is the P, that is the PR is not fixed, RR is fixed, but PR is not fixed. RR fixed, RR interval is fixed, but PR interval is not fixed. So this is the example of the third degree AV block, and these are the ECG findings of the third degree AV block, as because in case of the third degree AV block, there will be complete AV dissociation. Number of the P will be more than the number of the QRS complexes, and there will be no association between the P and QRS complex. So these are the ECG findings of the third degree AV block. And but the complete AV dissociation and third degree AV block is not synonymous. As for example, other than the third degree AV block, there are some other situations when you can see the AV dissociation, as for example, ventricular tachycardia and junctional tachycardia. So AV dissociation is a characteristic. AV dissociation is a characteristic of the third degree AV block, not the mandatory, that is not the only criteria. And AV dissociation does not always mean this is third degree AV block. As for example, in this case, that is the AV block, that is the AV dissociation can happen also in case of the ventricular tachycardia, the junctional tachycardia. As for example, in this case, this is the examples of the ventricular tachycardia. This is the P wave, this is the P wave, and this is the P wave. So there is the clinical dissociation. A number of the QRS complexes we can see, the number of the P waves, that is the number, that the P waves are also present, but we cannot see because of the location of the P waves at the different sites. Sometimes it is under the QRS complexes, so we cannot see, but these are the visible P waves. So the number of the visible P waves are less than the number of the QRS complex. This is one of the classic example of the that is atrioventricular dissociation, where the number of the P waves are less than the number of the QRS complex. This is the VT, but reverse is true in case of the supraventricular tachycardia, particularly the junctional tachycardia. So this is another example of the complete heart block, where we cannot see the conducted P waves. The PR is, that is RR is fixed. So RR is fixed, so this should be the AV block, but we cannot see the clean cut P waves, but we can see the evidence of the atrial activity by the fibrillatory waves. So this is the atrial fibrillation. So atrial fibrillation with fixed RR interval is an example of the third degree AV block or complete heart block. There may be bradycardia in case of the atrial fibrillation when the RR interval will be not fixed. But atrial fibrillation, if associated with the fixed RR interval, this is most likely due to the complete AV block at the level of the AV node. Another kind of the AV block we can see clinically in our practice life, that is the paroxysmal AV block. There is no evidence of the heart block in the patient's ECG or the some other findings, but this patient sometimes experience the syncope, and syncope may be one of the examples or the explanation for this kinds of the, that is that these stochasms or syncope may be due to the paroxysmal AV block. The definition is that abrupt transition from 1:1 conduction to complete AV block result in syncope is the paroxysmal AV block, but it is difficult to document. The level is usually the His bundle, and mechanism is sudden lengthening of the PP interval because of the intrinsic mechanism, either the phase 3 or phase 4 block. So this is the AV paroxysmal AV block, that is sudden lengthening, transition from 1:1 to high degree, and the mechanism is either phase 3 or phase 4 block. This is the example of the paroxysmal AV block. This is one of the example I have shown this slide previously. This is the 1:1 conduction, suddenly that is advances to 3:1 conduction. So this is one kind of the paroxysmal AV block. Suddenly patient develops. There should be explanation otherwise. This is the that is the paroxysmal AV block. This is another example of the paroxysmal AV block. This patient develops this cancer AV block during the intubation in the ICU, and possibly because of the high vagal tone, because of the pain during the intubation. So this is another example of the AV block that can be to the high vagal tone. So AV block happens, that is the paroxysmal AV block happens, but there should be some kinds of the risk factors of these groups of the patient. We can see, if we can carefully examine the documents of the patient, we can see there may be some right bundle branch block with or without fascicular block, or this patient has got the left bundle branch block or IVCD. Even this can happen in case of the normal ECG. The mechanism in this case is most likely the intrinsic and possibly phase 3 or phase 4 block. But in case of the normal ECG, may be due to the high vagal tone. So these are the examples or association of the paroxysmal AV block with some of the ECG findings. So this is the AV nodal block. Most of the times, the AV block we can define from the surface ECG or with the help of the Holter monitoring, but there is very less, but not unusual, that we can take the help of the electrophysiological studies. These are the indication of the electrophysiological studies. Class 1 indication, actually there is no class 1 indication, is none, but these are the class 2 indication, as for example profound first degree AV block with some other conduction block. This is one of the case scenario when you can take the help of the electrophysiological studies. Asymptomatic second degree AV block, we can see the actually the nodal conduction, that is his bundle, and that is the HV interval, or the symptomatic second degree AV block type 1. So these are the situation we can take the help of the electrophysiological study or the paroxysmal AV block. So these are the indication of the electrophysiological studies for defining the patient of the level of the block when the ECG or Holter does not tell the answer, not always, only in this case of the special situation. These are the indication. And pseudo AV block is another example. Another special group is the AV block in case of the myocardial infarction. The incidence is that the first degree AV block is nearly 15%, second degree up to 10%, and third degree is 7%. This is the incidence of the AV block in case of the myocardial infarction. The location of MI, particularly in case of the entry MI, 1/3 of the patient may happen some kinds of the nodal, that is the conduction, is not always the conduct, that is the third degree AV block, and the mechanism is either ischemia or infarction of the high vagal tone. So these are the AV block in case of the myocardial infarction, and the situation is different In case of the inferior MI, the entry MI, as per example, the infarct related data in case of the inferior MI is right coronary artery. In case of the 90% cases, circumflex 10%, but in case of the entry MI, it is always the left anterior descending artery. In case of the inferior MI, the location is usually nodal, entry MI is usually the infra-nodal. The pathogenesis in case the inferior MI is either the vagal tone or ischemic infarction, but is always the infarction. And evinodal block in case of the inferior MI, any kind first degree to third degree, but in case of the entry MI, usually the second degree or the third degree. So these are the some differences of the heart block in case of the myocardial infarction. And this is related with the blood supply. This was actually nicely described by Professor Chowdhury in the last class. That is the we can explain the different kinds of the pathology because of these kinds of the differences of the distribution of the arterial supply. As for example, his bundle dual blood supply, right bundle branch block, posterior fascicle, and the AV node has got the 80 versus 20, right coronary versus left coronary artery. So this is the some of the example what we can help to actually define the pathogenesis of the heart block in case of the infra. There are some questions actually. Why not always RBB in case of the left bundle branch, that is the entry MI? As because only 50% of the patient has got the one arterial supply LED, and sometimes in case of the 50% case, it may be the dual supply, that is the proximal part of the his bundle may be supplied by the right coronary and the distal part by the left coronary. So this is the reason that is the right bundle branch block is not always in case of the entry MI. And why commonly it is bifascicular block, as because LED supplies both the right bundle branch block and anterofascicle. This is the example. When right bundle branch block is involved, it almost always associated with the anterofascicle. So this is the reason the block is usually the bifascicular block. Why the left fascicular block is not less common, as because the posterior fascicle has got the dual blood supply. So it is usually the infection happens either by the right or the posterior fascicle is less likely to be involved. So these are some of the examples what we can see in the practice life. And this is the example of the AV block in case of the myocardial infarction. As for example, this is the anterior myocardial infarction. This is the anterior myocardial infarction. This is the second degree AV block, that is 2:1 block. The anterior myocardial infarction, the 2:1 block, that is the second degree AV block. But whether this patient needs pacemaker or not, this is the question. But the second degree, that is the anterior myocardial infarction, may be associated with these kinds of diseases, that is the second degree or the if it is a complete third degree heart block, no question. But what happens if it is the second degree AV block? And this is another example. This patient has got the inferior myocardial infarction with the bundle branch block, but again, here this infection is associated with the RBB, that is the right bundle branch block. So sometimes, not always, this is the classic, that is the anterior myocardial infection will be associated with some kinds of the conduction disorder, or the inferior myocardial infection, the QRS will be normal. This may not happen. Sometimes these kinds of the problem we can face. So we have to take the help of some of the guidelines. That is, these are the classic examples of the indication of the class 1 indication of the permanent pacemaker in these groups of the patient. This will be described by another class by Rafique sir. So these are some of the problems that we can face in the clinical life. But just for memory, that is the class 1 indication is second degree blood, not only this block. If the second degree heart block either symptomatic, or if it is associated with some kinds of the bundle branch block, or the symptomatic second degree heart block, or if it is the complete heart block, there is no question. So AV dissociation, what we can say, the AV dissociation, this is another example of the AV dissociation. The AV dissociation is not always due to the pathology of the AV node. Sometimes it happens in case of some other conditions, like this is this is the lead 2, the PR inverted. So this is the classic example of the atrial tachycardia that is associated with the AV nodal block. That is not the pathological block at the atrial level, but this is associated with the AV nodal block. And this is another example. This patient has got the actually LV morphology tachycardia, white complex tachycardia. Actually, this patient has got the atrial flutter with the late bundle morphology. So this group of the patient has got the block, physiological block at the AV nodal level and also at the late bundle branch level. So this group of the patient may show the evidence of bundle branch, that is the block level, both at the AV node and the bundle branch, that is at the multiple level of the conduction system. So this is also some ECG you can see. And this is another ECG. What we can see, that is the, this is the PP, but it is difficult to say whether it is sinus, that is AC nodal block, or the lead bundle, that is the AV nodal block. So these are the sum of the problems that should be discussed with separately. And this is another example. Actually, it was described by our Professor Chowdhury in the previous classes. That is, this patient has got the first degree AV block with the late bundle branch block. That is this kind of the bifascicular block. And again, this bifascicular block is progressed further and developed also the fascicular block. That is the first degree block, now the right bundle branch block and the anti-fascicular block. So the first degree AV block progressed to the, that is the right bundle branch block and the fascicular block. So what is the message? That is the bundle branch block is not a that is a static condition. It is the progressive disease. It starts from one side and can progress to the another side, and this is the reason it can be the multi-level AV block or multi-fascicular block like this. So conduction system block may be either at the AV nodal level or SA nodal level, or at the level of the bundle branches, either right bundle or left bundle. That is, the block may be AC nodal, AV nodal, multifascicular, like the bifascicular block or trifascicular block, or the multi-level block. So it is not the only AV nodal block what we can expect in case of the ECG evaluation. We can be actually ready to see that is this kind of AV nodal block may be associated with either the AC nodal block, multifascicular block, or multi-level block. And this is not the static. Now that the block is at the AC nodal level, but it can progress to the AV node or the further distal. This is the basis of the slide. So thank you very much for patient sharing. And this is something about the AV nodal block. And this is my request to Rafique Ahmed sir. Our actually participants are listened to here regarding the block, when to pace or not to pace. This is the very big, that is we have got many messages from our participants that they want to hear about talk on this, that is topic, that is the when to pace or not to pace. Actually, our upcoming talk, the next talk was Rafique sir, that is the ECG in the genetic disorder, followed by Zamil's talk, ECG in the children disorder. But I will request Rafique sir to give the talk on this topic just when he is comfortable. So thank you very much for this patient sharing. Thank you, sir.
Thank you, Atahar bhai. I have here.
Tushar, there are some questions in chat.
Sorry, yes, there are some questions.
Yeah.
Definitely.
Please.
The first question that comes is that, is there any possibility of tachycardia or normal heart rate in complete heart block?
Atahar bhai, did you?
Tachycardia, yes. Complete. So
in presence of
that
is there any possibility? মানে স্যার কমপ্লিট হার্ট ব্লক পেশেন্টের কি কখনো ট্যাকিকার্ডিয়া বা নরমাল হার্ট রেট আসতে পারে কিনা?
That is evidence of the ECG, evidence of the complete heart block with tachycardia. Yes, actually, the tachycardia, a complete heart block patient may be associated with the very fast sinus rate. That is evidence of the sinus activity. That is number of the P waves maybe more than the, that is the more than the 100. So this patient has got the high atrial rate, that is the sinus tachycardia. But there is the classic, that is the criteria of the third degree heart block, that is the RR is fixed, PR is variable. So if the P rate is, so this can be the explanation. I will request some other faculty to give some example explanation of this.
Can I something?
Yeah, I'll comment on that.
This, sir?
You can see it, not very common. You can see it in pediatric patient after cardiac surgery. Recently, we had a patient after bypass surgery. Patient developed complete heart block, but it was the right coronary was involved. So patient had younger patient, so had junctional tachycardia with underlying complete heart block. So you have to have junctional tachycardia or substrate for junctional tachycardia to develop. So it's possible. And that it makes it very confusing because what happens is that then it is tough to differentiate between these, to identify this problem.
Rafique bhai,
Yeah.
There is a fundamental issue on this question because I sometimes address this issue for the fellows. Tachycardia, what is tachycardia? Because the number of, the way we understand tachycardia is that number of QRS complexes, right? So there is another, I want you to comment on this question in the question section, and that will help to understand this situation. If RR is fixed, how AFib occurs? Is there a possible tachycardia or normal heart rate? So someone is asking, and this is an important, I'm sure that you can clarify this, that if the RR is fixed, how AFib occurs? Then I'll make some comment.
Tushar, the sound to
So the RR is regular. Why? How can it be AFib, right?
Right. That's the question.
Well, these are two different chambers.
Yes.
So we have the atrium, we have the ventricle. And if they become independent of each other, then the ventricle will beat at a regular rate because it will either be controlled by the AV junction or the ventricular escape beat. So you now have either a narrow QRS or wide QRS ventricular rhythm, which is extremely regular. And then on the top, you look at the atrial signal in the electrogram, you see atrial fibrillation. So that's why anytime we see atrial fibrillation with a regular RR interval, we always say this is complete heart block. And I actually have shown ECGs in the past that a patient was regular RR interval the day before. Next day, they convert to sinus, and you can clearly see they are in complete heart block. So that's the mechanism.
Yeah. Sir, another example to Dr. Chowdhury Hafiz, that is what happens in case of the atrial fibrillation when you do the AV nodal ablation.
Yes.
The patient of atrial fibrillation and doing the AV nodal ablation and who has actually.
Can you unmute non-speakers, please?
And we are producing the
mute non-speakers.
So, Chowdhury Hafiz, am I clear to you?
Yeah.
That is the atrial fibrillation and we are doing the AV nodal ablation. So there'll be clean cut. That is the atrial fibrillation and the escape rhythm either from the junction or from the ventricle.
Can I say?
And digoxin toxicity.
Block, the electrical activity of the chambers are different. In one chamber, the atria is conducting its own beat, the ventricle is conducting its own beat. If the atrial activity is not shown with the presence of typical P waves and the baseline is disturbed by the fibrillatory waves, then it's obviously RR could not be fixed and regular if the atrial fibrillatory rate, some of the beats are passing to the ventricles. If the RR is fixed, my baseline is typically fibrillatory, that means the fibrillation is confined within the atrium, there is complete heart block, and the ventricle is pacing at its own.
And I wanted to clarify to all that, because many young physicians are in the audience, that apical heart rate, pulse rate, tachycardia, these terms should be understood very clearly. Because in the AFib, you may have pulse deficit because the apical heart rate by auscultation versus the pulse rate may be different. It's very important. And then tachycardia, the way we understand, we don't talk about atrial tachycardia as when you talk about tachycardia, to patient is tachycardic. That means we mean that there is a ventricular rate is more than 100. So these are the important things to clarify.
And the thing is that in a previous class, Rafique sir was giving one example. In case of congenital complete heart block, if the atrial rate is more than 100, that's one sign that the patient is hemodynamically not stable. Atrial rate should not be, sinus rate should not be more than 90 usually. The patient is hemodynamically unstable, that congenital complete heart block is likely to require pacing. Sir, am I correct?
Yes, yes. I mean, that's one of the indicators that atrium body is telling the heart that we need more heart rate.
So one actually defined the complete heart rate. There are EP guys here, I don't know you will accept this, that the complete heart block is called, exists when the followings are there. Number one, there is AV dissociation. Number two, atrial rate higher than the ventricular rate.
True, but we have to prove there is no association. That is the most important criteria.
Exactly. There is dissociation.
That is A and B. But AV dissociation is not the only, this is the not only example of the complete. You are true. That is there should be a AV dissociation and number of the atrial activity will be more than the ventricular activity. True, absolutely true. But we must prove that is the A and B are not associated.
You have to be careful about one thing. Let's take a 85-year-old male who has 6 sinus syndrome with heart rate of 45 and then develops complete heart block with a ventricular escape rate of 45. You see, that is the place, or sometimes you can have a situation where there is antegrade complete heart block, but retrograde there is conduction and there is a retrograde POF. So it is not necessarily true that A rate would always be more than B rate. It is mostly true.
Right, sir.
Agree.
Okay.
Professor Jahurul Alam Khan is saying, VT is the example of tachycardia with complete heart block. Is the understanding correct? I differ.
Well, so Atahar actually mentioned that all complete heart block patients have AV dissociation, but not all AV dissociations are complete heart block. And there are many different examples of AV dissociation. One of them is ventricular tachycardia. Secondly, you can have a competing rhythm, that a junctional or ventricular rhythm competing with the sinus rhythm. That can cause AV dissociation. So not all AV dissociations are complete heart block.
Rafique bhai, I just want to add one thing. When we do the EKG scoring, they're very particular. If it is a VTAC, for example, for the General Cardiology Board, VTAC is good enough. They don't want to know where is the VTAC coming from. That's up to the EP guys. But if there is an AV dissociation, the EKG board, they expect that that it is identified. So to summarize this, VT can be associated with AV dissociation, but VT may not be associated with AV dissociation. There may be VA conduction 1-to-1. So in that case, you cannot say there is AV dissociation.
Yes, this can happen in about, sir, possibly in case of 30% of the cases, there is 1:1 conduction is possible in case of the VT. But in the rest of the cases, that should be the dissociation.
Is there any other question from the audience?
Sir, one question is there. Why atropine increases symptoms in case of infranodal block?
Atahar?
Sir, I will have you if you answer to this question, sir.
Well, atropine is an anticholinergic agent. And vagal tone only works on the sinus and the AV node. It does not work on the junction. So that's why atropine is basically not useful in case of if somebody has complete heart block with wide QRS escape rhythm, it's not going to be helpful. As a matter of fact, if you increase the sinus node, there can be concealed conduction and may worsen the situation. So white QRS, complete heart block, there is no need for atropine.
Sir, we have got no more question on this topic.
Sir Atahar,
Sir?
You have mentioned that secondary AV block with white QRS complex. Is it? You have mentioned that it is infra-nodal. Can it be infra-his or infra-nodal?
Yes, sir.
With what white QRS complex?
Sir, white complex usually below the AV node, sir. It is usually the infra-nodal, sir.
Infra-nodal or infra-his?
Yes, sir. Intra-his, yes, possible, sir.
If it is in infra-nodal, but before infra-his, then it should not be white.
Yes, sir. But if the location is AV node, if the escape rhythm from the junctional area, the QRS complex will be normal morphology. But if the escape rhythm is below the junctional area, that is AV node from the his bundle or bundle branches, usually it should be the white, sir.
Yes, this true.
The question holo if it is the escape rhythm is from bundle of his, is the escape rhythm is going to be narrow complex or wide complex?
Wide complex. It is if it is below the AV node, it should be the wide complex.
Well, a few things. One, you just think about it. If the signal is coming from the AV node, it is going through the common pathway. Yes. And if this patient has the underlying bundle branch block, then you will have a white QRS even with that. Second, if it is coming from any location above, before it splits into right and left bundle, you can get narrow QRS.
Yes.
Yes.
And it will only be if it conforms to any of the typical bundle branch. If we see that it is typical left bundle, typical right bundle pattern, then the escape is coming either from the his bundle or from the AV node. If it is coming below from that location, it will become totally a different morphology, which will be what we call non-specific interventricular conduction delay.
For example, in the limb it will be LBBP pattern, in the chest it will be RBBP pattern, something like that.
Yes. Yes.
No typical morphology.
No typical. Good lecture, Atahar.
Sir, my question is, if a patient has asymptomatic trifascicular block, PR interval not that much, 220, and BB with LHB or LPHB, what is the predictability that that patient is going to have complete heart block? What is the chance in future?
I have a patient who had atrial flutter. I put him on flecainide. He has baseline right bundle left antifascicular block PR interval of 240 milliseconds for last 10 years. I did not do anything. I did EP study because I was doing the atrial flutter ablation to confirm that the HV interval is normal. It was normal. So if there is no symptom, nobody has studied those patients. Because if trifascicular block, no symptom at all, then there is no need to study this patient. If somebody elderly patient comes with trifascicular block, and that means let's say PR interval of 240, right bundle left anterior has an episode of syncope, and which you think is cardiac syncope, then 99% of physicians today will agree that you should put a permanent pacemaker in.
Sir,
yes.
Sir, is there a role of exercise test to determine whether the patient will have any problem?
Oh, the question is that if I do an exercise stress test on this patient, well, yes, I mean, we don't routinely do it, but if you do a treadmill stress test on that patient and you find that they develop 2-to-1 heart block, then clearly there is a problem with AV conduction, and that patient definitely is going to, but those patients are going to present with exertional shortness of breath. I saw a patient just yesterday. This patient came, was fine. She has baseline right bundle branch block, doing fine. But last 2 weeks, she gets short of breath every time she walks from her mailbox to her home. And to the extent that she said, I went home and just sat down, down on the sofa. No, she didn't pass out. And on the 12-beat ECG, basically she goes in and out of 2-to-1 heart block. And I'm sure what was happening in real life, that why every time she walked, her sinus rate increased and her conduction went down and heart rate dropped, and she had exercise intolerance.
So we should be asking particularly when having any shortness of breath during exertion. That will help give some clue.
Rafique bhai, there was one sort of report in, I think, Stark or one of the AJC, that when there is a trifascicular block, those who do not have any, they divided the group like aortic valve disease or previous MI, and overall it is a bad news compared to normal conduction, but it was more likely that those who had previous MI and aortic valve disease, they had more problem requiring pacemaker. But when the index case is identified, trifascicular, it may not be an indication for pacemaker, but down the line with underlying structural heart disease, MI and aortic valve. So we need to be more vigilant on those groups.
Yeah, absolutely. I mean, if there is any doubt, I mean, let's say if somebody, you can always study his conduction, his bundle. And if the HV interval is long, then you put a pacemaker in. And looking at the HV interval is a very simple procedure. Takes about half an hour.
But your suggestion is good. A cheaper way to do chronotropic response maybe, right?
Yeah,
absolutely, absolutely.
That's what, actually, that's what we suggest.
Okay, shall we do the questions?
Yes, sir. We can go for your suggestions.
Sir, Motin's question. Rafique, sir. Yeah, we are waiting.
Okay, so we'll do questions. I mean, as I have done that, I always try to keep it to the relevant topic, but please be careful. It's not always true that I will keep it to the relevant topic. Because that's how real life is. Patient don't announce that I'm going to come with MI today. So our first ECG, this one, and I've given the choices.
Vivu, please show the poll box.
Yes, sir. Starting the poll, sir. Sir, give us 1 minute, sir. Starting the poll.
Sure. For the audience, while we are doing this, oh, good, poll is started. I request as many people as possible to answer. That is, nobody knows about it, and if you answer and your answer is correct, it will confirm your knowledge. If your answer is wrong, that will also help you so that you will not make the same mistake next time. So please do answer. Commit yourself to any answer. And remember, none of us are always correct. If we were all correct, we would not be discussing all these things amongst us.
So, sir, 30% of the attendees voted for it. 88% says it is C, sinus bradycardia with otherwise normal ECG. Sinus bradycardia with otherwise normal ECG. 88%.
Ribu, can you show the number of the participants in the bracket?
30% of the attendees voted for it. Out of 30%, 88% says sinus bradycardia with normal ECG.
Sure. So I'm going to touch 5% said.
Rafique bhai, one second, Rafique bhai. Yes. There is no tracker that anybody is answering or not. So we should really encourage participants to answer because nobody is tracking them.
Yes, yes.
Because we want 100% answer.
Yeah. So the question was that 5% said sinus rhythm with 2 to 1 heart block. And I'm sure if I gave this ECG not today, another day, probably majority would have agreed with number 3, which is the correct answer. Now, if I talk to the physician who answered number 1, 2 to 1 AV, I'm sorry, I made a mistake here, AV block. If this is the P wave, let's go down. I'm going to look at the rhythm strip. In the lead 2 rhythm strip, I'm touching P wave, Qrs complex, P wave, Qrs complex. If it was 2 to 1 heart block, there should have been another P wave just in the middle, which I don't see. Now, one may assume in lead V1 this terminal portion of the T wave as a P wave, which is a possibility, but it's not 2 to 1 then. So please remember that this is sinus bradycardia, otherwise normal ECG. Please keep this picture in mind. Every time you look at an ECG, whether this looks rate like this or faster, is sinus rhythm normal ECG. That is a picture that we must remember in our brain so that 90% of patients will have this ECG. Okay, next one. I'm going to go. Paul, please. Yeah. I will ask Wadud to discuss this ECG because I think he gave the talk on hyperkalemia.
Yeah, thank you, sir. The thing is, the patient obviously have bradycardia, and the bradycardia is quite profound. Now, for bradycardia, is it sinus? I should have a P wave before the Qrs complex. Lead 2 do not show anything. V1 do not show anything. So it's not sinus. But there is a problem in here. The V1, the first complex shows somewhat of a complex like that. But that probably is the transition that is creating this. Because the next bit on V1, it doesn't show that. Now, the other thing is that hyperkalemia. Look at the T wave. All the T waves are quite peaked. T wave, narrow base peaked T wave with bradycardia, no PR cut P wave is very suggestive of hyperkalemia. Complete heart block, it is not, because I should see the P waves. It's not. Atrial fibrillation, it is not. We are not seeing the fibrillatory wave. So 3 or 4 is out. Sinus bradycardia or junction bradycardia, that too you should think. Hyperkalemia is the clue that will be suggesting that this is going to be the correct answer.
Yeah. So the other thing about the T wave that Wadud mentioned, that look at the T wave is bigger than the Qrs complex.
Yes.
This is the definition of hyperkalemia T wave. The T is so tall. So this patient had a potassium of 7. I wrote in Japanese so that nobody can understand what I'm writing. But, and then same patient, so what mentioned that narrow tall peak T wave, intraventricular conduction at decreased amplitude or absent P wave, ST segment change, simulating injury. You see, look, there's some ST elevation in lead 2, 3 AVF. So those changes, but those are related to hyper. Same patient, when the potassium goes down to 5.5, you can see that there is P wave, Qrs complex is within how many days? Next day, potassium is back to normal and normal ECG now.
Go mane ki 5.5?
Yes, 5.5.
আমরা শিখে ফেলছি।
Whoever is answering the multiple choice question, there are 2 ways of answering. One is randomly answering, and then second, random answering with some reasoning in my mind. So this is good. 70% said junctional block. Now the question is, 13% said sinus rhythm with junctional premature beat. Now, there is a reason that I gave this choice. And what is point in their favor? Any of my panelists can dispute that if they say junctional is premature beat, why not it is junctional premature beat? I mean, if I look here, this bit, I don't see any P wave before QRS complex. So there can be, it can be a junctional premature bit and it is early. But the point is, there is a degree of group betting. But let's start from this bit. We have PR, and then PR gets longer. And the next PR, you see the P is at the end of the T wave, longer. And I think now the P is inside the T wave, and that did not conduct. And then we have short. So this is a very typical Wenckebach phenomena. So always have to imagine that this P wave, because they get buried in the QRS complex. So that's the answer. It's not atrial fibrillation because there is a pattern to it. There is visible P wave. So that is out of question. So one answer that I will not accept at all is atrial fibrillation. The rest I'm willing to accept and debate. So please remember, to be atrial fibrillation, there will be no P wave at all, but we have P wave. So that is something that we must not say in this, but other choices, I'm happy to accept, but the diagnosis is sinus rhythm with Wenckebach AV block. Yeah, so this is a good distribution. Anybody, any comment from our panelist?
Sir, looking at V1, that gives you the clue, because here we see a V1, we see a P wave that is not conducted.
I am not sure. That looks like I don't think the majority, I would go with the majority, Rafique bhai. I think there is, all P's are conducted, right bundle and left anterior fascicular block, left axis deviation. And there is first degree AV block. So I will go for A. Because I don't see any dissociation.
No, Chowdhury, it is 2:1, clearly 2:1.
2:1. I like to say 2:1. If we lead to this P is conducted and this non-conducted P, this P conducted, this non-conducted P, just overlapping the T wave, that is 2:1, and another RBB and also left anterior hemi block. That means 3 is correct.
Number 3.
So what I do, first of all, it is not complete heart block. Why? Whatever it is, there is a P wave and there is a QRS complex, and there is a definite relationship between the two.
Yes, sir.
So let's exclude what it is not. So the totally wrong answer will be complete heart block. And then we can debate rest of them. The other answer that is wrong is, let's look at the Qrs morphology, right bundle and left anterior fascicular block. So number 2 is definitely wrong, because I did not add left anterior fascicular block. So now I am left with sinus bradycardia with first degree AV block, right bundle, left anterior, or 2:1 heart block. Now, anytime I see in a patient with bundle branch block heart rate of 40-45, I always try to look for a second P wave, just to see if there is anything. If I look in lead V1, this is a biphasic P wave. There is a biphasic P wave. This is a funny looking T wave. And if you look over here, you can, as if this is a P wave. So this is actually 2:1 heart block with the baseline first degree right bundle left anterior fascicular block. This ECG is in 2007. Now look at this same patient had another ECG. I don't have that one. Sorry, I did not put a couple of years ago. Now this is a different patient. So this is 2:1 heart block. So please remember that. Now, of course, if you look at the other leads, it becomes very difficult to identify. So in these cases, you have to keep a high degree of suspicion. And a lot of physicians will miss this ECG. This is a common mistake. I had patients who have gone to the operating room with this ECG and developed complete heart block during surgery with catastrophic outcome. So, and it is very important to find the second P wave.
But Rafique,
yes.
We say that we are debating on these two differential. How to be sure that this is the 2-to-1 or this is trifascicular block?
Okay, so yes, so 2-to-1, you have to, then you can do rhythm strips, number one. If you exercise this patient, it will get worse. What will happen? The P wave get buried in the QRS complex, unless they develop 3-to-1 heart block. So you have to look for other rhythm strip or put an unusual electrode that will show the P wave a little bit better.
This electrode.
Yes. So, but I think the V1 is the clue here. This is no question about it, especially this ECG, that the pointer where my pointer is the clue to this one.
রিভু তুমি ইসিডি দেওয়ার পর পোলটা একটু পরে দিও কারণ সবাই একটু
রফিক ভাই, I politely disagree with the 2-to-1 because you cannot map the PPs. Because when you look at
yes. So that is the thing.
You cannot map. That's why I did not agree.
Okay. Now, this is the problem. Look at here in
No, the original
one.
Show me the original one.
Oh, this is a different one. Okay. Yeah. So, yes. So the problem is that this is why the confusion is that this patient, if this is not a V1 T wave. If you do longer strips, you will find that this is not the T wave. This is the distortion. So this patient clearly had, and actually what happened, I don't have the pacemaker ECG. Once we put the pacemaker in, you could see that the heart rate totally changes in this patient. But as you say, that if somebody writes sinus with first degree AV block, that a lot of cardiologists will write that, but this patient can have serious consequences if we miss this 2-to-1 heart block.
I think the message I take, whoever is right, is underlying structural heart disease and further evaluation is needed before we go for further. But I would, on the surface EKG, Rafique bhai, I'm sorry, I will still take the trifascicular block.
Okay, all right. No, fine.
And then evaluate further.
Yeah, let's look at this one.
রিপোর্ট পোলটা একটু পরে দাও কারণ সবাই একটু দেখতে চাচ্ছে দেখে তাহলে ওদের আনসার করতে অসুবিধা হচ্ছে তুমি 20 সেকেন্ড দেখতে দিয়ে তারপরে পোল দাও আমাদের একটু সময় নেই পোলেই বরং সময় কম দাও 20 সেকেন্ড সময় দাও 30 সেকেন্ডের জায়গায় এটা তো ঝামেলা জিনিস পেয়ার ইন্টারভ্যাল ফিক্সড এটা আসলে একদম মাপা উচিত
এখন পোল দাও
রিপু তুমি 20 সেকেন্ড ওয়েট করে পোলটা দিবা
ওকে স্যার ওকে
all participants are requested to answer as because
it need for our own assessment.
Is good numbers number C.
Okay, at least I'm happy that number B was very few. It is not idioventricular rhythm because it's a right bundle morphology. Looks like typical right bundle morphology, so it is not an idioventricular rhythm. So the question is, sinus bradycardia, first degree AV block, right bundle block. C is 2-to-1 heart block, and then few physicians said complete heart block. Question is, B is out, I think, and thus question will be D. So there is a P wave and there is a QRS complex. And if we look at the interval, they look same. So there are probably some association. So one possibility is this is sinus bradycardia with first degree AV block. Again, when somebody has bundle branch block, 82-year-old person, I don't remember his symptom, I always try to look for another P wave. And if you look at lead V1 over here, and then look at the T wave, there is clear negative. In this case, Hafiz cannot dispute me.
Totally agree.
Yes, now there is a P wave. But
I'm looking at your choices, Rafique bhai, because you are actually very fair to give the choices.
Yes. Yes. So, but this P, I mean, if you suddenly gave me this one, if you just gave me this QRS complex, I cannot make any comment. I can say probably a retrograde P wave or something, or maybe artifact on the QRS T wave, but it is present in every tracing. It looks exactly like the P wave that is before. And then, so diagnosis is 2-to-1 heart block with right bundle branch block. And let's see if I put the timing here. Okay, yes, I did the timer. Look at this timer. The RR interval is 1600 milliseconds.
Yeah.
And then if I add the P wave,
yes,
if I put 2 P wave, is exactly 1600 milliseconds. There is a little variation here, 1630 with this one and 1640. But for the most, this is 2-to-1 conduction. And the first P wave, the second P wave. So I think the timing is also very important. Putting a caliper is very, very important. And you can see there is some variation of the P to P interval. It's basically QRS complex can change the timing a little bit.
Sir, can I say?
Yes.
The previous ECG. The last QRS complex and the PR interval, and the first QRS complex and the PR interval, there's quite difference.
Yes, that can explain.
That creates some confusion.
Yes, that can explain there is some variability in the, and it can happen, but it is not a dissociated complex, especially in this location. So there is, when there is first degree AV block, there will be some oscillation of the PR interval with autonomic tone. So you are absolutely right. This first one is different. And of course, they can swing between 2-to-1 and I have patients who will go into 2-to-1 heart block and complete heart block, intermittent. They're floating around, depending on which part of the tracing you get.
Sir, sir, most important message for a participant is that we have to see the T wave very carefully, particularly in V1 and lead 2, whether there is another P waves or not.
Yes, absolutely. Okay, how about this one? Let's give them some time.
Pulled up.
Please also pay attention to the computer-generated report that will bring up to an important, and this is one of the part of American College of Cardiology ECG exam that we are also given computer without computer report and with computer report. Okay.
That's nice.
Yes.
Good, sir.
Yeah. So the question is, any panelist have any comments? Sinus bradycardia with left bundle branch block. And the distribution is kind of interesting. So,
yes, sir.
Go ahead.
Sir, I am with the most of the participants, sir. That is the number 4, as because there are some evidences of the conducted.
But why not? No, fine, but why not? How do you say it is not sinus bradycardia with left bundle branch block? Why not? With some sinus arrhythmia, maybe.
Because in case of chest leads, there is the V5, V6 are complete, clear-cut negative complex. So it doesn't correspond with the limb lead absorption of left bundle block only. I can see the interventional conduction delay that much, but not
important is that there are some evidence of the conducted as well as non-conducted P waves, sir. As far as the bottom strip, this is the conducted. That is the second bit is the conducted P waves. That is the next one is not conducted. Third is conducted with it is also not conducted. That is the second, fourth, sixth are the conducted bits, sir.
Well, let's ask the person with controversies. Hafiz.
I'm actually with 4, but I can see that, first of all, Rafique bhai, you are ignoring all the MIs.
No, this is a rhythm ECG. Hafiz. So no, we are not going to do any cardiac cath today, Hafiz.
So, but
my question is,
I look at the lead 2.
No, why not number 1? What is the problem with number 1?
Why not problem with number 1? Because it does. If you look at there is PQRS relationship in the rhythm strip cannot be justified by sinus rhythm alone.
Yes.
So if we say sinus mechanism is there, but the AV conduction is problematic. So in the EKG of worksheet, we would be writing sinus rhythm, probably sinus bradycardia, but AV conduction is problematic here, and only can be explained by high-grade AV block in the first half and complete heart block in the second half. More consistent with that.
Yeah. So I think let's look at it. People who answer sinus bradycardia. So this is the P wave, QRS complex. PR interval is about 240 milliseconds. So if that was the case, this P wave is too close to be conducted. And then this may be conducted, but this one again too long. Okay, let's make an assumption that this conducted and this conducted is a longer PR interval. If they did, then the RR interval should have been longer here, which did not change. So the RR interval is absolutely regular, and P to P, there is no relationship in this part. So let's look at the timing. Here I have the timing. So RR interval is 15-20 milliseconds, absolutely correct, with P to P no relation. So this part is complete heart block. Problem is, there is a P wave and there is a QRS complex. And this QRS complex is much earlier than that before again it becomes 15-20. So this most likely is a conducted P wave, QRS complex. So this patient, that is the definition of high-grade AV block. That means mostly complete heart block, there are some conducted QRS complexes. This is what we call high-grade AV block. And everybody, I'm sure the panelists will agree on this diagnosis, right?
If we look at the worksheet, maybe not a bad idea to follow the worksheet for mentally in our head that what is the origin, sinus, AV conduction, QRS, subsequent conduction, any axis, hypertrophy and pattern, and then disease order. Last week I showed the worksheet that because that way I think it is much easier to follow through.
Oh yes. So, I think in the learning process there are two issues. One is the algorithm, the worksheet, definitely to use. Second, a picture memorization is also very important. That we remember the pictures and then justify why it is this, why it is not this. Okay, So I have similar ECGs, a couple of them, but again, the same thing. No, we have shown this one before. Just 1 second.
But I have two EKG for the panelist. Even I don't know the diagnosis.
Okay, we'll do this one, and then I'll go half of the ECG, and then probably one more ECG. Okay.
Sir. Paul. Nice.
Yeah, so I think we're getting better here. Yeah, so people who answered B should also be correct, considered as correct, partly because you just missed the left anterofascicular block. So if I add 8%, 82 plus, so 90% actually gave correct answer. And then sinus rhythm with first degree AV block, again, somebody when there is this kind of bradycardia always look for a second P wave. Second P wave. And so if we look at lead 2 rhythm strip, you can see this is P wave. I'm going to give the timer. I have the timers. So this is the P wave, P wave, P wave, P wave, P wave. So you can see the P wave clearly. If you have any confusion, if you think this is the U wave, then go to another lead, see if there is a negative complex. And the timing is 660, 620. This makes 1280. See the RR interval is exactly 1280. This P to this P is 666 to 660 millisecond and 1320. So the timing is right on time. And this is all measured. I measured it just this morning. So this is clearly 2-to-1 heart block. Look at this patient. This patient, right bundle left anterofascicular block. This was done in December of 2018. Where is it? In 2014, patient had left bundle blind block. So this patient actually has significantly diseased conduction system. And it is good to look at the old ECG. So I think we can stop here. And then I want to show just one ECG before we move to Hafiz's ECG. This one. So
this one, sir?
This will be the last ECG. Please look at it, and then we'll give the this ECG can be very confusing ECG, especially on rhythm, and if you look in the rhythm strip on telemetry monitor. The computer determined the heart rate of 117 beats per minute.
See.
That's good. So the machine was totally confused. The machine recorded heart rate of 117. I think what is happening, if you look at lead 2, these are the big P waves, and the QRS complex is almost same height. And it is probably double counting these numbers. And that's why it ended up with this. So if I look at the marker channels with this, so you can see the P wave, P, and there's a 600 millisecond. But look at the RR interval is 870, 940. there is a little bit of variation 980, but definitely there is no relation between P and QRS complex. And why this is variation? This is a patient with congenital complete heart block and with some bundle branch block. And they actually, the junction can change rate a little bit. So this patient was like that and had right atrial enlargement. Look at the rhythm strip. When you, and the telemetry monitor, the P wave and QRS complex are almost same height, and it can be very confusing in this patient. Thank you. And Hafiz has
is it like a ventriculophasic variation? It is allowed. But yes. The P wave, what is the congenital heart? Is this P wave gigantic?
I forgot the history. I forgot the history, but had significant right atrial enlargement.
Yeah. It's the Himalayan P wave.
Yes.
Yes, sir.
Epstein, sir.
Epstein-like, sir.
It looks
possible.
Like
I can find out what the story was. Okay, Hafiz.
I need to share the screen.
I will, yeah.
So Rafique bhai, I am sharing the screen. So I was in the board review course long time ago, and Dr. Shahabuddin Rahmatullah was doing this EKG session. He said, no fighting, no quarreling. And then he said, I don't tolerate any opinion. Just listen to what I say. Let me see whether I can get this. So actually it was from yesterday with our EKG conference. So I just told the fellow to send me. Okay, see, we called it EKG Halloween cases. Halloween is today. You know, Halloween is a big thing in the US. That they think that all the ghosts come to the earth. Okay, so not this one. Let me. I don't know how much time I have, so I'm going to show you the one that we are still struggling.
You haven't shared the screen yet.
Can you see my screen?
No.
No. Okay. Let me see this. Share. I should be able to see now.
We have started sharing, but not yet visible.
Slide.
This is both sinus and ventricular arrest now.
We have not seen it, sir. It has not come to us yet. 7 সমুদ্র 13 নদী পাড়ায় আসতেছে তো এই জন্য দেরি হচ্ছে।
আচ্ছা এখন হচ্ছে না?
না।
Really?
Slide share যাওয়া লাগবে, slide share.
আমি তো গেলাম slide share.
It has not still come to us.
Resume share. It says, you can see no?
Yet not, sir.
বের হয়ে স্যার আবার ঢুকতে হবে স্যার।
হ্যাঁ? আবার ঢুকতে হবে?
জি স্যার।
No, why?
এদিনে একই প্রবলেম ফেস করছি আমরা।
Hafiz is not, I can't see Hafiz. You have to turn your video on.
Okay. Turn the video.
Yes, now share it, please. Now try to share, see what happens.
But I don't see the file in the...
Okay.
Oh my God.
আপনাদের আস্তে আস্তে আমরা একটা কোশ্চেন করি স্যার। একজন কোশ্চেন করছিল ওই যে আগের একটা ইসিতে স্যার এলবিবিবি না আমরা বলছি, তো হি ওয়াজ কনফিউজড হোয়াই উই আর নট সেইং ইটস এলবিবিবি।
Well, yes. The reason you are not saying this is not LV because lead 1 was left bundle morphology, but lead V1 through V6 was a negative complex.
Exactly.
Now, there is a problem. Sometimes what happens, if there is hypertrophy, the heart can be rotated. And if you do V5, V6, V7, V8, then you can see actually the complex as left bundle. So sometimes you can have to do extra lead. But that was the reason that, Wadud, I assume that you mentioned it was not typical left bundle because of that.
Because for left bundle, and V6 has to show similar morphology.
Yeah. Another question there was that where is the QRS coming from? If in complete heart block, QRS is narrow, or it conforms to one of the bundle branch morphology, right or left bundle morphology, then it is coming from the junction or his area. If the QRS have no other morphology, it looks like a ventricular premature beat or ventricular tachycardia, idioventricular rhythm, then it is coming from the ventricle itself.
So you were saying in one of the ECGs, the answer could not be idioventricular rhythm because the morphology was RBBB type.
Exactly. And that is a typical pattern. And then there was so it is not a ventricular rhythm. It is driven by something other than the ventricle itself.
Okay, so it's saying that your screen share is paused. So it's paused in my side or?
I think on your side, sir.
I cannot unpause it. Where do I unpause?
Remove from IT. Can anyone help?
We can look at it next week, Hafiz.
Okay.
প্রবলেমটা হচ্ছে স্যার
ওটা
স্যারের এন্ড থেকেই হচ্ছে না স্যার স্যারের কি নেটের স্পিডটা স্যার কি একটু কোনো আপ ডাউন হচ্ছে স্যার
না আমাদের এখানে মেসেজ দিচ্ছে your screen sharing is paused but I did not do any pause
এইখান থেকে স্যার কোনো কিছু পজ করা না স্যার আপনাদের স্যার আমি কো-হোস্টও করে দিছি স্যার এখন
স্যার আপনাকে ওখানে আসলে এপিআই বুঝে দেখতেছে আপনি কি মেসেজ পাঠাচ্ছেন
oh let
Rafique sir, assalamu alaikum. Sir, there was a question sir যে Wadud sir বলতেছিলেন আমাদের একজন পার্টিসিপেন্টস কোশ্চেন করেছিলেন যে alternate bundle branch block RBB LBB is it always indicator of trifascicular block or it can be due to rate related aberrancy? How can we differentiate that?
Oh, so the question is alternating bundle branch block like this patient had. You know, if you think what we call complete left bundle branch block with QRS duration of 120 milliseconds is complete left, and few days later develops right bundle branch block. That patient should be in complete heart block. How come it is not in complete heart block? And now there is proof that actually what we call complete left bundle branch is not complete left bundle. There is some conduction, so you can go from one side to other side, alternating right and left bundle branch block. Rate-related aberration, of course, it can be rate-related bundle branch block also, but with the rate that's slow, you don't expect that to happen.
Exactly.
So it is not rate-related. I mean, rate-related will be if it is tachycardia dependent bundle branch block. So that's how.
Another thing possibly he wants to know, sir, whether it can be called trifascicular block or not.
Oh, the trifascicular block definition is.
Afis, very good news. We can see all the lectures and everything. Hafiz bhai, can you hear us?
Hello, ECG. Yes.
I think they are having.
Can you hear me? So 22-year-old with trauma came with this EKG.
Can you
you have to open it.
Your ECG is not visible.
We see the screen of all those
Can you see the EKG now?
No, sir.
It is your computer screen. We're just seeing your computer screen, nothing else.
You have to open the file, please.
Just open the file, sir. Then screen share.
ECG case is Halloween.
Yes, first file you have to open, please.
File, yes, sir.
Oh my God. I'm seeing it, but I don't know. I think we'll have to do it next week because.
Next week, we'll do it next week. All right.
Sir, do you have any more ECG, sir, Rafique, sir?
No, I think we're done. I think it's Bangladesh এখন তো রাত কয়টা বাজে 11টা বাজে
আচ্ছা
Atahar bhai, can you ask one of the technical guys to hang on because I need to figure this out that how it to do it.
স্যার একটু বলবেন স্যার আপনার এখানে স্যার কোন ফাইলটা ECG
review
first one Halloween EKG
স্যার ডাবল ক্লিক করেন স্যার তাহলে হবে স্যার ECG কেস হ্যালোইন এইটার উপর ডাবল ক্লিক করেন স্যার
It will double click.
First file, right?
Yes, sir.
I think it's opening up.
Can you see now?
No, sir.
No.
Well, that's the problem. I don't know why.
Achha.
Okay, if I go to screen presentation mode, it doesn't come, right? No.
Achha. An alternative suggestion, Hafiz bhai.
Yeah.
From the next weekend, you can see send the ECG before the session to our technical guys.
Okay, that's a good one. Yeah.
They will share the screen.
Okay. All right. Thanks.
You
Okay.
send your email or something like that, or who else is here? Technical.
স্যার আপনার পাওয়ার পয়েন্টে স্যার রান করেন আপনার কি স্যার পাওয়ার পয়েন্টে স্যার কোনো ঝামেলা আছে স্যার এমনি আপনার এখানে স্যার পাওয়ার পয়েন্টে রান আছে স্যার
পাওয়ার পয়েন্টে রান করতেছে হ্যাঁ পাওয়ার পয়েন্টে ক্লোজ করে দেব
শেয়ারিং কিছু হয়েছে
আপনি যেটা করবেন যে ফাইলটা শো করবেন ওইটা ডেস্কটপে নিয়ে আগে ওপেন করবেন তারপর এটা মিনিমাইজ করবেন তারপরে শেয়ার স্ক্রিন করবেন আপনি
ফোল্ডারে আমি ডকুমেন্ট থেকে আসতেছি আচ্ছা ঠিক আছে
ফোল্ডারে গিয়ে ওপেন করার দরকার নেই আপনি এটা ডেস্কটপে আনেন ওপেন করেন মিনিমাইজ করে রাখেন তারপরে জুম থেকে শেয়ার করেন
তারপরে স্লাইড স্ক্রিন শেয়ারিং এ গিয়ে ওইটাকে
কিন্তু আমার এটা বুঝতেছেন আমি এই আপনাদের সাথে প্রোগ্রামে আমি এই প্রবলেমটা দেখতেছি আর কারোর সাথে আমি দেখি না আচ্ছা ঠিক আছে
Possibly because of difficulties.
It is difficult because I wanted to actually see what you say because even we don't know what is happening. But anyway, so maybe we'll show it next week.
Next week.
ঠিক আছে.
So Firoz, just for few minutes, one more ECG. Just for few minutes. Here is Mohsin. Just share the screen. And ask Mohsin to.
Mohsin bhai, this is the courtesy of Professor Mohsin Hussain, 70-year-old gentleman presented with palpitation. 12-lead ECG is below. Was given propofenone 150 milligram 12 hourly for this. The interpretation rate 134 beats per minute. Rhythm rate irregular, QRS and X is normal. P wave is replaced by flutter waves, sawtooth appearance with variable AV block, more marked in inferior leads. ST segment normal. So the diagnosis is typical atrial flutter with variable AV block. Any of our panelists have got any opinion with this?
No, it's clear cut. The next ECG is actually interesting.
This is the next ECG. ECG after 2 weeks of propofenone. The rate is 150 beats per minute. Rhythm regular. QRS axis normal. P wave absent. ST segment normal. T wave normal. QT normal. So the diagnosis is atrial flutter with 2:1 AV block.
আগে ভেরিয়েবল ছিল previously it was variable, now it has become 2:1. The rate is increased. What was the question?
The confusion I think would be why not it is a sinus tachycardia.
Yeah. So I mean, if we give this ECG, there is no way I can definitively say this is atrial flutter with 2-to-1 except for the fact that this is rate is 150.
150.
If you look at lead V1, it appears to be there is a P wave which looks like almost like a sinus P wave, initial positive, then negative, with a PR interval slightly prolonged. So one can always say it is sinus tachycardia with first degree AV block. Then you look at this ECG and you find this patient is in 150 beats per minute for next 2-3 hours. It cannot be sinus tachycardia. So then it will put you a diagnosis. Either I have to entertain all of them. With this ECG, previous ECG is different. But this ECG, I'll have to consider long RP tachycardia. And one of them will be atrial flutter with 2-to-1 conduction. It can be an atrial tachycardia. It can be an atypical flutter with 2-to-1 conduction. Or it can be an SVT
Yes.
with long RP tachycardia, SVT.
Sir, sinus tachycardia to long RP hobe, sir.
Exactly. So, but the thing about sinus tachycardia is that if you do this ECG and half an hour later, it is still 150. It cannot be sinus tachycardia, because sinus tachycardia will not stay at a fixed number. If you do it now 150, 5 minutes later, it will be 148, 158. So it will keep changing because there is intrinsic variation of the sinus rate.
Sir, just to clarify, inappropriate sinus tachycardia ki bola jete pare, sir, if the tachy persists in that way. Inappropriate sinus tachycardia.
But okay. That is slightly variable.
Okay, to define somebody as inappropriate sinus tachycardia, you have to prove that the P wave looks like sinus P wave. That's first, one of the things. Because here, I cannot see anything. I cannot say what the P wave is like. So let's say if this patient comes to me with a heart rate of 125, and I can see the P wave, which is upright in lead 2-3 AVF, and biphasic in lead V1, then I will point more towards the diagnosis of inappropriate sinus tachycardia. But with this one, I'll have difficulty to say that. But I'll have to enter all the diagnosis.
These are clinical points. 70-year-old.
Yes.
We started on propafenone. So after the first EKG, I think we need to be very clear about evaluation and then think about a class 1 drug on the propafenone. And the second, 150 sinus tachycardia, 70-year-old at rest. I have a lot of trouble to digest that as clinical. And the third is that 150, I know you don't probably like this, like many EPs, that 150 is a magical number with narrow complex, particularly who had atrial flutter before. So now it is in that range that it's 2 to 1. So it is important that we don't give the wrong message that I would not use propafenone without further evaluation and make sure that structure in normal heart, etc.
For the juniors, you see, before you give class 1 C drugs, you have to be sure the patient is not having ischemic heart disease or any other structural heart disease problems, because in that case, you are going to increase the mortality. That's what the Asan Bhai was emphasizing.
So, Firoz.
The answer, Mohsin.
Discussion, propafenone or flecainide.
Mohsin উত্তরটা দেখাও না, কি explanation, কোশ্চেনটা ছিল কিছু ওর, কোশ্চেনগুলো কি ছিল?
Rafique bhai, if we know that the previous EKG and the propafenone given, then my best bet is that it has now flutter rather than anything else.
Oh yeah, no question. I mean, I'm saying the reason we're discussing 150, our primary diagnosis will be atrial flutter, but you cannot say it is not anything else, because especially the second ECG, the first one is different.
That's why I will say it one is interesting. Firoz, can you just Firoz, তুমি তো পড়ে যাবা?
Now, তোমার discussion হয়েছে.
Okay, yeah.
And the last line is most important.
একটা কথা আমি বলি,
আবার দেখাবো স্যার।
না,
ওয়াদুদকে বলি একটা কথা। আমি ফ্লাটার দেখে চিন্তা করি, রফিক ভাই হাসবে, যে আমি দেখি যে ফ্লাটার অ্যাবলেশনে আসছে কিনা ক্যাথ ল্যাবে, তখন আমার চিন্তা হলো যে এটা কি মানে কুইক প্রসিডিওর না লং প্রসিডিওর। সো ইপিরা বলে যে তোমরা পরে ক্যাথ করো, আমরা এই ইপিটা চট করে অ্যাবলেশনটা করে নিই, কিন্তু আমি দেখি যে যদি লেফট সাইডের ফ্লাটার, তার মানে এটা চট করে হবে না। রফিক ভাই এই ব্যাপারে
No, okay. There is a big difference between intervention. Only jeta chot kore hoy intervention. EP is never a chot kora business.
Exactly.
So it is not like this. EP you need to think about it. You need to have a mathematical mind. And as my professor used to say, you can train anybody to do intervention, but not because you have to think. And the patience, is the personality will have to be different. You cannot do EP unless you have a very calm mind and open mind. You go in and you don't say, I'm going to finish at what time. We never say that. I can only tell what time I'm going to start the procedure, because it is not like that I have 20 patients waiting that I have to finish the intervention.
That's why I don't trust the EP guys without looking at the EKG. I don't give the lab without looking at the EKG, because they will say that, oh, this is right-sided, no problem.
Oh, no, this is a problem, because you see, your lab is a multifunctional lab. An EP lab and intervention lab cannot be the same lab. It has to be a separate lab, because once I start the procedure, I have to finish it. I cannot wait. And my theory is, if I start a procedure and God comes and asks me to come out, I'll say, please wait, you can destroy me later on, but I am not coming out of my room. And as simple as that. So you have a significant flaw in your lab, Hafiz. You cannot have an intervention lab and EP lab in the same room.
So we have 3 labs. We have 1 dedicated EP. But I'm just saying, those who have 1 lab and they share, you need to be, I have gone through that.
No. You cannot do that. You cannot have a shared, you can do pacemakers. You can share pacemakers, but you cannot have EP procedure and intervention in the same room. And we expect that they will finish at a certain time. It cannot work. And that the centers that have 1 lab should not be doing EP, because they will not have enough skill to do that. Because if the EP guy is not doing electrophysiology every day, then he should not, it doesn't matter how trained he was, he will not maintain his skill. It should be closed.
Totally agree, but unfortunately, many are becoming implanters, not doing EP.
Well, no, that will depend on what phase of the career it is. I mean, pacemaker implantation is also part of electrophysiology, but that's a minor part. Doing pacemaker is like doing intervention. It's a repetitive, boring procedure. So that's different technology.
Sir, one question has come up. If a patient has complete heart block with junction escape rhythm in AF, how can you say junction escape rhythm is due to AF or sick-sinus syndrome when we do not have old ECG? Do we need to implant pacemaker when patient has complete heart block with nodal escape rhythm in AF? I mean, without below Pandobras.
Okay. Please, we get confused with, Jamil actually pointed that out, definition of sick. Once somebody develops permanent atrial fibrillation, we should not use the term sick-sinus syndrome anymore.
Yes.
Because now the patient is in permanent atrial. Maybe it is a consequence of atrial fibrillation. Jamil, you agree with that?
Yes, sir.
Yes. That's not permanent atrial. Don't use the term sick-sinus syndrome when somebody is in permanent atrial fibrillation. That's out of the question. Second, when somebody have atrial fibrillation with slow ventricular response, there will still be irregularity of the RR interval. If the RR interval becomes perfectly regular, that means now the patient has developed complete heart block, either due to conduction disease or drug like digoxin, whatever it is. Even if you give high dose beta blocker, they will still have irregular RR interval. So they have to develop some kind of complete heart block to become regular. Whether to put a pacemaker in or not, that's a different story. Because somebody with atrial fibrillation on digoxin develop digital toxicity and heart block, I'm not going to put a pacemaker in, I'm going to hold the drug. Somebody develops high-grade block because high dose of beta blocker or calcium channel blocker combination, I'm not going to put a pacemaker until I allow the drug to wash off. So you have to let the drug to wash off before you make a decision about implanting pacemaker on this patient, unless you can say that, well, those drugs are absolutely necessary for this patient and there is no way of stopping the drug. Or in a situation where If I stop the drug, patient becomes extremely tachycardic, and if I give the drug, they become bradycardic, then you can put a pacemaker. So please be careful about the indication of the pacemaker implantation.
That's very good explanation. Thank you. Atahar bhai, Firoz, do you want to finish?
Yes, sir. It's 11:15. I think we can finish. Sir.
Thank you.
Thank you, sir.
What is the topic next week?
Atahar bhai, unmute. Atahar bhai, unmute.
Sir, please unmute yourself.
Sir, next week's talk, sir, आपनार ECG, yes, sir. ECG in genetic disease. तो सर आपने ECG in genetic disease बोलबेन ना कि सर वही talk टा सर when to pace or not to pace.
এটা স্যার খুব অনুরোধ স্যার, এটা খুব দরকার। এবং what type of pacing we should choose in what disease type of disease.
So we can do next week. We will do bradycardia ECGs plus pacemaker ECG combined.
Right, sir.
It will be a hybrid lecture.
Sir, that will be fine.
Okay, sir.
Okay, all right.
Sir, we want to have a, but for the junior, they want to have a clear guidance about choosing a pacemaker for a particular situation. What type of mode they should be doing.
Okay, all right.
আতার ভাই তাহলে আমি এক সপ্তাহ পিছাইলাম।
জামিল
জি এক সপ্তাহ পিছাই দেন আমারে।
আচ্ছা জামিল, তুমি হচ্ছে যে আগামী সপ্তাহে যে সারের লেকচারটা আছে না, তারপরের সপ্তাহে তুমি।
ওকে ওকে, থ্যাংক ইউ।
মানে কামিং স্যাটারডে, নেক্সট স্যাটারডে
আমার জন্য ভালো হয়।
আচ্ছা ঠিক আছে তুমি।
ঠিক আছে। Okay, bye.
You think about some a topic and you choose what you want to talk about. We want to have a very good lecture from you.
Arun, how are you doing?
Fine, sir. I have some internet problems, so I'm not joining.
Good. All right. Take care. Good night. So
anyway, I'm enjoying.
Okay. All right. Bye. Gobindo, bye.
Welcome, Arun.
Right, sir.
Assalamu alaikum সবাইকে।
Assalamu alaikum, sir. Assalamu alaikum.
Assalamu alaikum. Good night.